Okay, once again, welcome everybody to the CDI Forum. This is an ongoing series presented by the Compliant Coding Systems Coding Academy. The CDI Forum is hosted by Tariku McKinnon, MD, and Brian Kui, RHIA CDIP. Tariku, Dr. McKinnon, and Brian will be your hosts for the CDI Forum. Going forward. And so today's topic is, why is CDI crucial in healthcare settings? So we are going to turn it over to Dr. McKinnon and Brian and let them run the show.
All right, everybody, welcome to our first CDI forum brought to you by Compliant Coding Systems. I want to thank you guys for having us, me and Dr. McKinnon, here this evening to talk about why CDI is crucial in healthcare settings. And so I guess we'll begin with the first slide with Dr. McKinnon, right? So you'll begin with this slide.
Thank you, Brian. Welcome everybody to our first webinar session. We actually brought a wide kind of topic, but in the future we'll come up with more specific things to discuss in detail about specific issues in CDI. So our today's topic is, why is CDI crucial in healthcare setting? And I personally always start talking about CDI by bringing quality before talking about any reimbursement, any cost, and other issues. The reason for that is usually for a healthcare provider, quality is at the heart of what we work, at the heart of what we aspire for our patients, for our facility. So how does CDI affect quality? But when we say about quality, if you ask a physician, how is your quality of service? He can tell you, like, my quality is good, my quality is, so. But at the end of the day, the next question is, can you objectively show me the quality of service that you're providing? And this is when the CDI functions come into picture. Unless you have a specific documentation, you cannot infer or you cannot bring a meaningful statistics or meaningful conclusions about the quality of care. And once you have a specific picture once you see the picture about the quality of care, okay, I have a problem with these issues in terms of quality. What can I do? What kind of things can I bring? What is the interventions? And you implement that intervention and you follow if your intervention is working or if it's not working. Again, you go back again and see the documentation and the kind of statistics that you bring out of that documentation. So when we say, or when we talk about quality, the most important thing is, do you have enough evidence to talk about quality? And that's when clinical documentation improvement takes that stage. Core quality measures, when we think about quality model in general, there are different steps. The first thing is input. What can you bring into the whole process? Input can be a structure. And when we talk about input or structure, what is your facility bringing to provide the service? How many beds do you have? What is the capacity, the diagnostic capacity? How many nurses do you have? How many physicians? How many specialties? All these things are costs. Quality is not cheap at all. So you have to bring a lot of resources into the mix. And the next step is, once you have this basic ingredient, do you have the process? Do you have the process measures? You need to have a certain set of procedures, tests, surgery, sequence of actions. What can you do when you have a patient with pneumonia, when you have a patient with sepsis. When you have a patient, if a patient comes with sepsis, do you automatically go and give him antibiotics, or do you start by taking cultures in other laboratories? So there is a step and there is a sequence for every specific condition, and we need to put that in process. And talking about quality, unless you meet requirements or set of indicators in that process, you cannot reach the quality, which is the outcome indicators, preventing of hospital-acquired conditions, reducing mortality, reducing morbidity, and reducing readmission rates. So all in all, when we discuss about quality, we need to have a meaningful statistics, and the hospital has to utilize whatever is available by strengthening the clinical documentation improvement program within their facility to see where the hospital stands in terms of the quality of care and the avoidable readmission rates. Otherwise, unless we follow everything, we will just wake up out of nowhere and face a lot of penalties and payment adjustments which negatively affect the reimbursement and everything. Brian, do you have anything to add?
Yeah, thank you, Dr. McKinnon. Just looking over this slide, some things kind of pop out for me, especially with the core quality measures. Some key things to consider when you're looking at core quality measures, especially with the outcome indicators, are things like congestive heart failure, pneumonia, pressure ulcers. You see their HACs, avoidable readmissions, and mortality rates. You want to make sure you are reviewing the documentation and also assisting the physician to make sure the documentation is clear on things like HACs, present on admissions, and things like that. In regards to preventable event measures, especially with post-operative conditions, those things affect, on a data standpoint, the quality. And I guess when we go through the rest of these slides, you'll see how it kind of fits in there. Can we go to the next slide, please? So for this slide here, the reason for how CDI impacts healthcare today, especially with reimbursement and utilization. Now, Dr. McKinnon mentioned first in regards to quality. Yes, that is the big focus, and yes, reimbursement is another, but it should not be the primary focus. And as we go through the slides here today, and Dr. McKinnon, I think we'll talk with the next slide, the key is, yes, we need to make money because, yes, healthcare is a business, but that should not be a main focus. But it is a focus nonetheless. So in regards to tie-in with quality, with reimbursement and utilization, we want to look at our documentation, making sure that we are looking at the severity of illness, risk of mortality, length of hospital stay, and ultimately, with CDI, it's all about the appropriate coding and DRG assignment. We're looking at things at CMI, relative weight, length of stay, making sure that documentation with conjunction of the principal diagnosis, secondary diagnoses, fall into classification with the correct DRG, MSDRG, APR, DRG. In regards to that, in assigning that APR, DRG, or MSDRG, we can effectively justify those resources utilized for those patients. Especially with coding guidelines, we're looking at principal diagnosis, principal procedure. We want to make sure those are effectively in place, justifying one another. And when you look at secondary diagnoses, we want to make sure those are justified as well, especially when we look at complications and comorbidities and major complications and comorbidities. The last thing here is in regards to risk adjustment. There's a new tie-in to risk adjustment with HCC coding. It all depends on the accurate patient profiles, and we look at a few things here that you see on the slide: health status, chronic conditions, current versus resolved conditions, and also looking how a clinical specificity in terms of its documentation can impact risk adjustment. Is there anything else you want to add in, Dr. McKinnon?
I mean, you said it very well. When we talk about reimbursement and utilization, we need to justify every little thing that we see in the patient, every little diagnosis that we come across, and the kind of services that we provide for the patient. A lot of times, physicians don't really have the grasp of what comes after the patient is discharged. So for them, the reimbursement, the resource utilization is just not a priority. But it's up to the hospital management and everybody within that hospital management category to come up and to give them the idea of what is on the other side of the formula, so when physicians understand that whatever they put has a lot of ramification in terms of reimbursement and resource utilization, they tend to have a very positive kind of reception for clinical documentation improvement. But usually, they unless you give them a good introduction and a good insight about all these things, they usually tend to have a very negative attitude towards this whole process of documentation, and they usually tie it to only reimbursement and utilization and forget about what it means to the patient, what it means to the hospital, and what it means to their own profile. Okay? Do you have anything, Brian?
I think we're good on this slide.
Okay. Can we go to the next slide?
We can. I think I was going to just jump in here with a little bit on risk adjustment, okay, and just kind of hit some of these bullet points here. The whole foundation of risk adjustment depends on accurate patient clinical profiles. In other words, a very accurate clinical picture of the patient must be drawn, and that all comes from the documentation. In our risk adjustment program, there's an example, certainly under the ICD-9 mapping model, where if hypertension and chronic kidney disease is not specified as to the level, it will not risk adjust. However, if it is end-stage renal disease, it will risk adjust. So, if a provider does not take the time to, or take the care or the caution to document that stage of chronic kidney disease, it could mean the difference between an HCC that qualify for additional premium payment to the healthcare plan versus not. So it really does depend on an accurate patient clinical profile, the health status of the patient being accurately represented, chronic conditions showing continued management, and one of the things that happens is physicians, when they see a patient for years for diabetes, they become a little lax in their documentation because they feel that it becomes redundant. But under risk adjustment, especially Medicare risk adjustment, these have to continually show treatment, okay, or attention. So current versus resolved conditions, and providers will use the term history of cancer. When the patient actually does not have a history of cancer, they're still being treated for the cancer. So that's just a verbiage that providers sometimes use that can be problematic, and that's where clinical documentation improvement efforts can play a role. And again, just the example I gave a moment ago, clinical specificity can vary, can impact risk adjustment in a very poignant way. So, this risk adjustment, if you don't know about risk adjustment, it is becoming the underlying current of financing healthcare. Used to be for Medicare and Medicaid. Now it's under the Affordable Care Act. It's just as applicable to commercial insurances as well. So, risk adjustment is another area that is emerging and requires very accurate clinical documentation, and that's where CDI efforts can assist with risk adjustment as well.
Thank you, Doug. The next slide talks about accurate profiling and benchmarking. You know, when we say about profiling and benchmarking, a facility can be benchmarked and compared with other facilities within the state, and you can compare what the facility is achieving in terms of quality from within the national average. Okay, so do we have the means to do benchmarking? It's been we've been doing that for facilities. You can go to Hospital Compare. You can go to healthgrade.com. You can check medicare.gov/physician compare and different things, and they are starting to compare hospitals. So clients have a you know, an informed decision about where to go. But the future is even more and more going towards comparing what this physician is doing in terms of quality compared to the other physicians. So it is coming towards that direction. So we already have this Hospital Compare where we can go and check how is the hospital doing in terms of a specific condition. Let's say you have a COPD. What is the mortality rate for the state? What is the mortality rate for the nation? And how is the facility doing in terms of that mortality rate? So it shows the client, oh, this facility is doing good in terms of this kind of parameters. It could be mortality rate, it could be readmission rate. So there's already this benchmarking and this comparison when we go to those public sites. But the idea of benchmarking comes at the end of the day with documentation. So when you have a specific and a very detailed documentation about the patient's condition, then you can say, okay, the quality of care is over here. But unless you have that kind of documentation, the benchmarking by itself is just a figure which may not reflect the actual and the accurate condition of the clinician or the hospital. So some of the things are, let's say, case mix index. So case mix index is something big when it comes to reimbursement. Brian has told us a little bit about in the previous slide about reimbursement, but it also, the reimbursement is also calculated through case mix index, and it reflects the severity of the patients that you are caring for. Unless you capture the comorbid conditions, unless you capture the major comorbid condition, then your case mix index is going to be very low. So the kind of things that happen when the case mix index is very low, the hospital has to panic, you know. Why is the case mix index low? Do we sometimes when you have a surgical procedure or surgical services that you are not doing it anymore, it kind of dramatically go back, or lowers the case mix index? Or is it because we're not documenting those kind of things? So when the case mix index goes down, it has to press a panic button for the hospital administration, and they have to say why this happening and what are the causes, and come up with a solution. And at the same time, personally, if the case mix index jumps up like from one month to another month dramatically, it has to be, I mean, I see it with caution. Are we actually putting the right diagnosis? Is there any fraudulent practice? Or do we have any new procedures, any new surgeries coming into picture where it dramatically increases the case mix index? So it may really give us a lot of things by simply looking into the case mix index from month to another month. It gives us the trend of our quality of care, the resources that we're putting for our service. And the other thing is core measures. Brian mentioned a couple of things about core measures. The list of core measures is getting bigger by each day, and at the end of the day, these core measures are the indicators of quality that we're providing. If you have a patient with acute myocardial infarction, and if you are not giving that patient aspirin on arrival, and that specific core measure is going to be like low, weight, low, So you cannot say I've given our patients the best quality of care when the core measures for different conditions is like very low. So you have to justify, I am giving a quality care for our patients or for my patients, and you can see in all those core measures, the percentage that I'm providing is very high, And the other thing, again, the physician quality reporting system, the value-based purchasing, the physician value-based payment modifiers, all these things are like a system of encouraging quality service. When we have a quality service, all these things that we have listed, the 3 bullets will be positively affected. So a lot of directions is like towards tying the quality with reimbursement. You're not going to be reimbursed unless you justify that you're providing a quality service. So come 2017, the physician's value-based payment modifier is going to be enacted in a very full force, and they already have started the physician quality reporting system since 2015. So they have the data, they have everything, and in the future, the physician's payment is going to be scrutinized based on the quality of service that he provides and the amount of the level of expenses that he puts towards achieving that quality. So we have to ask, like, is the hospital getting a credit for the service that we're providing? Is the physician getting the credit for what's being done for their patients? But at the end of the day, to justify everything, we need to have a very strong and very thorough clinical documentation improvement. And do you have anything, Brian?
Yes, I guess you went through a lot of this, but there's also some more to it. The way I kind of see this slide in terms of looking in terms of the physician quality reporting system and also hospital reporting and benchmarking, you got to look at it like a report card. And the report card really falls into documentation, right? So from a coding standpoint of view, you're looking at documentation, proper coding, proper DRG assignment, and that leads to that first bullet point again, to case mix index, right? And so when you look at the case mix index, and depending on how, I guess on a yearly basis for one facility, that will ultimately determine the hospital base rate. So you can have 2 hospitals, right? Same, I guess, bed capacity, same services, right? They can be providing the same everything. And ultimately, if their CMI can be, one could be higher, one can be lower, and that will ultimately determine that hospital base rate. The hospital with the highest, not highest, but the higher CMI will result in receiving a higher hospital rate, meaning that they'll be paid more compared to hospital B. It's the same thing with physicians. You know, you're talking about here physician value-based management modifier. From what I understand now, physicians are also based upon their report card paid upon a rate. And so you can have one physician who does like sees 12 patients gets paid less than another physician who only sees 5 and gets paid more. So yes, we're tying in that financial impact, but again, you know, I guess the idea is in order to be rewarded financially, you must be providing that quality care, and it all comes down to, yes, I mean there's always a constant discussion. Oh, you know, I'm worried about my documentation, but you know what? That's where the bottom line is. It's in documentation, and it's not the fact that the physicians are alone. That's why CDI specialists are out there to assist, to help, to guide, to guide that proper documentation, so that way your report card is high and you get better reimbursement. Okay. Can we move on to the next slide, please? And so for the next, I guess, impact for CDI impacting healthcare is especially with ethical documentation. I know we talked about quality, we talked about financial reimbursement, we talked about benchmarking, but when you look at it from a ethical standpoint, we got to make sure, or we have to make sure, or physicians need to make sure that their documentation reflects the care that is being provided on an ethical standpoint. Now, when we're looking at that, we want to make sure that, hey, look, there's something that happened during the surgery. We want to accurately reflect what occurred in that operating room, or what occurred during that code blue in the ICU. Those are things that need to be accurately documented, and CDIs are there to kind of pick up those things and to make sure that those are properly reported. Yes, it may impact finance. Yes, it may impact quality, but you know what? It comes down to proper ethical documentation. And as the definition here, definition of ethical documentation is the recording of accurate, complete, consistent clinical documentation within the health record for reporting healthcare and to coding that data. I already talked about medical legal issues, but also patient safety issues. There have been times where I have reviewed records and without going into detail, have identified conditions that I have had to bring to the physician's attention because nothing was done in terms of documentation, nothing was done in terms of treatment. So because of me catching those things, those were brought up and those became a preventable issue with the patient record. Anything else you want to add on, Dr. McKinnon?
You said it very well. Just a couple of things about ethics by itself. Ethics is just a set of certain rules that we have to follow. And when it comes to documentation, as you said, the coder has certain rules to follow. The coder has certain ethical things that he has to follow every time he code. And at the same time, the physician has also to document things like appropriately and correctly. He should not, the physician should not cover the kind of or falsify records or cover complications, and at the same time they have to also accurately put the severity of the patient. So when we think about fraudulent documentation, it usually comes to do we say fraudulent documentation from the point of covering up our mistake or trying to increase the reimbursement? But can we also think about the other aspect of unethical documentation, where we don't document anything after doing so many things for the patient, and by not documenting specific things that we have done for the patient in terms of the diagnostics and management and everything, it affects the patient's health in the future, and at the same time it affects the reimbursement of the hospital. So at the end of the day, we have to also think about, by not documenting thoroughly, can we think about the level of fraudulent documentation from that point of view? So I'm just putting something for a thought. Usually we think about fraudulent documentation when we add a lot of things just for the benefit of reimbursement, or when we try to cover some of the things, some of the mistakes. But what about leaving everything without documenting? It affects the patient, it affects the hospital. So it's just a discussion point. Okay, next.
So I will jump in here for a moment and let everybody know that part of the agenda for each CDI forum is to provide a forum, an open floor for questions, for comments. We have people from all walks of the industry. We'll certainly have providers, we'll have CDI specialists, we'll have coders, and we'll have aspiring people wanting to learn more about CDI joining us. So part part of this is presentation on the part of the subject matter experts, both Dr. McKinnon and Brian, but we encourage your participation and to bring your questions, to bring your comments, to bring your experience vignettes, and share these, and perhaps let other people benefit from either your question or your comment. So with that, at this point, we want to turn the floor over to our audience, and feel free to ask a question, to make a comment. You can speak directly to Brian and Dr. McKinnon. If you are in a place where maybe you are unable to verbalize, you can always use the chat feature. And so again, you have the floor. So do we have any questions or comments from anybody in the audience today?
I guess one thing we get the question here, I did want to add to the last slide. You don't have to change the slide, by the way. But in regards to ethical documentation, a lot of things that we talked about, especially in trying to increase reimbursement and try to improve quality, there are times that I've had to provide a clarification with the physician because the physician was really documenting conditions that were not clinically there. So, for example, sepsis, and I did a presentation on sepsis, so that's ingrained in my head. And so, especially now with ICD-10 out there on the horizon, I believe physicians now, with their training, have gotten very worried about their documentation, so they are aware about how ICD-9 has impacted healthcare and how ICD-9 reflects their documentation. And sometimes doctors tend to just jump the gun and say, okay, look, this patient has this. But when you look at the clinical indicators as a CDI specialist, you'll look at it in a way like, well, it doesn't match. And so there are times, I'm not going to say, hey doc, I don't believe what you're saying, and you went to med school and so forth. I think you're wrong. But the way I would approach the physician says, look, here's the cards, here's what the patient has. You wrote this. Can you please clarify why you wrote this? And things like that can definitely either downgrade the condition from a severity standpoint. Yes, it'll impact quality. Well, actually, no, it won't impact quality, but yes, it will impact reimbursement. But you know what? It comes down to that last slide, ethical documentation, making sure that we're not fraudulent and the doctor is accurately, consistently documenting care.
Thank you, Brian. We do have a question that was placed in chat, and that question is, where is the best place to get the documentation guidelines for individual conditions? So, first, I guess, are there specific documentation guidelines, for specific conditions, and if so, what is the best resource for that?
Speaking about specific guidelines for specific conditions, there are so many documents, so many supporting books on CDI, and they usually have a specific conditions. Let's say you have sepsis, you have UTI, you have pneumonia. Based on the patient, the different conditions, what are the things that you need to look? What are the things that you need to document? So we would probably put the list of those things, those references on our page. Doug, can you tell them?
Yes, we can certainly put those out on the resources tab. And one thing that is important to note is for specific conditions for this is the whole idea of clinical documentation improvement. I don't think there's any one guideline. It's really a marriage of guidelines. Your coding guidelines for coding and reporting. You've got your quality guidelines. So you want to look at your quality measures. So you want to look at, I don't think there's one place for these guidelines. You have to look at, all of your guidelines, your quality measures, your guidelines for coding and reporting, so I don't think there is one particular set of guidelines. So we had another question. How do you know what you can and can't say in a query so that you're not leading a provider? Although we will have this in upcoming Wednesday night is going to be the query and overview, and we will have more specific detail in future presentations on different elements of the query. But Brian or Dr. McKinnon, do you want to answer just generally some of the highlights of leading, maybe perhaps addressing the leading of a physician in a query?
Yeah, a lot of times, one of the, as you said, we'll come back about that in the coming webinar. But the reason why we need to have a very organized CDI program and ensuring the query process is legitimate, compliant, and the CDI professional knows how to approach the physician, what to write on a written query, what to say on a verbal query is something. It has to be an ongoing process. So you have these issues of leading the physician right and left, and the CDI professional has to be well educated in terms of what kind of wording that he has to use, what kind of sentences that he has to put on the written queries. So it's a very critical issue, and it's a very legitimate question, and we face it like right and left. And sometimes one CDI could be very good in terms of understanding the implications of all these things, but it all goes to training the CDI professional and looking into the kind of queries that he put and tracking those queries and look into the quality. What do you mean by doing this? Sometimes there is no information, and out of nowhere he's asking a physician and he's giving the physician a kind of options to choose. But the rules are very clear. You have to use the indicators within the patient's document to present that to the physician. When you present it, it should not be a leading kind of query. But leading is like a very, very wide term. So maybe we'll discuss it in detail. But like you said, it is a very critical issue, and sometimes even within one facility, one CDI professional, I have seen a lot of CDI professionals who, within one facility, it could be one CDI professional is doing the writing and the other is not doing the writing. It's partly because of education and understanding of these whole conditions, and that's why you cannot just implement a CDI program and without quality assuring it. It's going to be very, very, very grave, because it has a legal connotation when you start leading the physician and getting those CCs and MCCs, which affects the DRG and of course the case mix index and everything. That's why Medicare, usually when a facility increases the CMI or the case mix index out of nowhere, and they usually ask, why is it going like that? Is there any fraudulent query process? So it happens right and left, and we will discuss in detail about what is a leading query, examples of a leading query, so we can talk so many things about that. Brian, do you have anything to add?
Yeah, well, with the queries, I would kind of say there's an art to it. um, I kind of consider like a chess match. And you hear some of these terms. I'll definitely kind of elaborate more, I guess, in the future session in regards to queries. But yes, it is an art form. There is a way of communication. You have to properly communicate what you're trying to portray and what you're trying to get at with the physician. And it comes down to what I'll call it as the three-legged stool, making sure that you are justifying everything in the documentation. As a CDI specialist, your job is supposed to comb that chart thoroughly, right, and present to the physician nuggets of information that will help the physician make a decision about the patient's care and ultimately in the documentation. So, it is an art form. I mean, I'm telling you from experience. I mean, I've started with no experience, and I've made the really, really, really bad queries, and now, you kind of develop that experience that you kind of develop. To me, it's an art form, and how to kind of produce a query that a physician will automatically look at it and says, "I agree," or "I will give you this input," or that's to the point where the physician is comfortable at looking at that query and answering it right away. That's the key, and that's the turnaround time that you want to have. To go backwards a little bit on the first question, where's the best place to get documentation guidelines? I mean, to me, my background has been in medical coding, so when I learned CDI compared to someone who's a nurse or someone who's a physician, I learned it from understanding coding in terms of the guidelines and then moving backward to understanding the clinical aspects of a disease. So when you're looking at a query, it all depends, in posting a query, it all depends on the condition that you're trying to query for. And, my basis of setting up a query is based upon really coding guidelines on how to select the proper code. We're talking about things about specificity, acuity, type, and all of those things. But then, I have to understand, look, in order for me to get the physician to write that, I must support it again with clinicals. And when I first started out, I was Googling left and right, and this is why it's important to have a collaborative CDI team for those that are trying to create a CDI program, to have a multidisciplinary team. So that way, for me as a coder, I would go to a nurse. Hey, look, I always call my nurses, and they're wonderful. And I say, look, I have a question on this condition. What is the treatment? Could this be something that can be documented this way? And they help me out that way. And through the years, the same regard, the nurse will help me out and say, look, can this be coded this way based on these criteria? So, there's a lot of things in regards to the query and learning. There's a big learning curve for sure, especially with nurses and coders. But it has to be done right away, and that's why with this program, hopefully with the CDI program, you'll get an understanding of what to do. And for me, at least, being part of the with coding compliance, I will tell you what my experience is, and it's not the fact that I'm I mean that I'm a super expert or whatever, but I will tell you from my experience what are the best practices, what has worked, what has not worked.
Yeah, and it's a process, it's a process. Like you said, when you start, there's always some sort of very, very difficult conditions, what kind of queries to put, how to word it, and what kind of informations to bring. It depends from a specific condition to another condition. So the basics is you have to always bear in mind that this has legal implications. And the next thing is you need to have a coding knowledge and at the same time a clinical knowledge. So if you are a good clinician and if you are a good coder and if you kind of mix it together, when to put a query, how to put a query, but always the most important skill comes when you do it a verbal query. Because a written query, you can follow it, you can judge it, you can look into the query and say, oh, this wording has some issues, don't say this one, when you bring this kind of information. But when it comes to the verbal query, again, that's also a very gray area. It needs a lot of experience. But we'll come back to these kind of things in the future and probably put specific examples of a compliant query, a leading query, a non-leading query, and we discuss on based on that kind of things.
Yeah, Dr. McKenna, I think you know, we have a number of different sessions planned just on the query. This coming Wednesday will be an overview of the query, but then we do plan on breaking it down in future sessions to very specific parts of the query. So we want to make sure that we are able to move on to some of the other questions. So I think Sharon is going to help us moderate some of these questions here. And so the next question, Sharon, is, are there documents?
Okay, there's another question that we receive. Are there documents that indicate the level and specificity of documentation for individual conditions? I think it's more for, like, let's say a coder or a, let's say for a coder, how do the coders get more knowledge on where and when and what to query, as to how do they find out if a condition could be documented in a more specific way than what it was originally documented?
I guess I'll step in on this one. When coders go through their coding programs, and a lot of times, as I advise students, when I was teaching HIT programs, the first thing I tell them, I said, look, you are in a coding program, but what's most important is understanding your clinicals. You take anatomy, physiology, pathophysiology, pharmacology. I'm kind of taking it a step back into the schooling aspect, and also understanding the medical record itself. So with all of those things, when I say medical record, and a lot of times in terms of coders, the main issue is, they're so hard into understanding the coding, assigning the code. To me, the coding is the easiest part. The most difficult part that I've seen amongst coders is actually trying to find that information, you see. And where does that lie? It lies in that education on understanding your clinicals. You get that document, you get that education. It's a matter of you capitalizing on that, so by utilizing that knowledge, that will help you alongside with understanding the medical record, understanding, look, here's a condition that I need to work on. I know, for example, CHF, congestive heart failure, there's a few things that I need to look at. I need to look at, echocardiogram with an ejection fraction. I need to look at chest x-ray and look for things like pulmonary edema. Those are the key words. Those are medical terms that you need to look at. I need to look at laboratory values. I need to look at pro-BNP. What's that? Those are things coders must understand to look for. Looking at what kind of treatments, Lasix, IV Lasix, Coreg. What is that? Those are things that as a coder, they need to understand. Those are the pieces that are required in order for you to assign that code. And what I've seen coders do is they just assign the code without knowing what is it that they just coded, So in terms of specific documentation, it's in the record, but the question is, do you know where to look for that? And that kind of takes a step back either to your education or mentorship or, just being out there and understanding your research and gaining your own self-knowledge.
Yeah, just to add on what Brian has said, at the end of the day, if the physician put every diagnosis as much specific as possible, then there will not be a problem for a coder, because they're good from the coding point of view, but we don't expect them to know the right and left of a clinical condition. So that's why the CDI function come into the picture. And like Brian said in the previous one, when we talk about the different models of a CDI program, that's why you need to combine the coders with the clinical professionals like nurses and physicians. If you have that kind of model, then there's a very good synergistic kind of interaction and understanding between the coding side and the clinical side.
Thank you very much. We have...
Yeah, Sharon, I'm sorry. Before you read the next question, we have about 9 minutes left and about 3 chat questions going. So, just want to make sure we are able to get these in. So, go ahead, Sharon.
Okay, another question that we received: is there something in writing somewhere that states that we can only, or coders can only code what is documented? That we can only code the verbiage and not a code, or that we cannot code the intent of the documentation? Is there anywhere that is documented that coders can only code what is documented?
You know, that really falls on the individual facility policy. And if you're asking for the documentation, that's where it is. It's that policy. It depends on the coding manager, what they decide to consider, if it's documented, how many times it's documented, if it should be coded. But there's 2 words that I've always kind of had ingrained in my head, is the clinical truth, right? And so when you're coding, ultimately, or even so in terms of coding CDI, it's ultimately to do one thing, to promote that clinical truth. And in the end, when you're looking at things, when let's say, for example, a record is audited by the RAC, you know, it comes down to not just the coding, but then where does it step back to? It steps back to the documentation. It steps back to those clinical indicators to support that documentation. So, you know, in a CDI program, you know, and we'll talk about metrics, you know, in a future presentation. But you know, one thing to consider is, you know, you have the CDI specialist and then you have the coder. Of course, the CDI specialist will, you know, assign a, I guess, initial DRG while the patient's still in the hospital, and the coder will assign the after discharge DRG. Of course, at that time and moment when everything has been assigned, there's going to be some type of discrepancy, and it's usually because something, you know, saying, well, the coder says I assigned this because it was documented, and then we also have the CDI saying, well, no, it is documented, but it's not clinically justified. So, you know, there needs to be somewhere of a tie-in and a collaboration between the CDI department and also the coding department to make sure, you know, before this account gets closed, we need to, you know, make that policy and procedure, which is that documentation, to make that final say.
Thank you. Dr. McKinnon, anything to add to this?
I think because we don't have much time, Brian has said it, you know, in detail, and we can go ahead for the next question.
Okay, so next, if we only have diabetes with renal manifestation, can we code 250.40 without any code for manifestation? Do MDs write it this way until they determine a manifestation?
I'm not sure that Dr. McKinnon is probably has 250.40 committed to memory, so this may be a question for Brian to at least begin answering.
Okay, can we repeat that question one more time? I'm sorry.
Sure. If we have only diabetes with renal manifestation, meaning if it was only documented that way, DM with renal manifestation without a specific manifestation documented. So can we code it as 250.40, which is DM with renal manifestation, without assigning any additional code for the manifestation itself because it is not documented? So our second part of her question is, do MDs or do doctors write it this way until they determine a manifestation?
You know, my answer to that is going to be, well, we need a query, right? So, I think you mentioned 250. I think that's the diabetes code,
Yep.
and ICD-9. Maybe I'm just trying to. I don't have a record in front of me, so based upon what you said, I'm thinking that probably the physician wrote in the patient's history, patient with diabetes or diabetic nephropathy, without any mention. But again, as a CDI, you want to look at it, I guess it goes back to that previous question. Should that be coded? Why? Because you need to look at if it's, number one, does that cause a risk for the patient's care? Number two, you got to look again at those clinical indicators. That's the key. Looking backwards, not just on the documentation, but then kind of taking a step back and looking at the supporting pieces of data in the healthcare record to support that. So, as a coder, you want to, I think, as what we think of coders, it's like a black and white situation, and what we need to kind of consider is there's a gray area, and those are things you can't really make a fine, a quick judgment on, and as a coder, you want to not make that quick judgment. You want to bring in a second level review, bring in a CDI, you bring in a physician, bring in a nurse, get that collaboration, so that way, if diabetic nephropathy or diabetic renal manifestations. I've never seen a doctor write that, but it might be diabetic nephropathy without a manifestation due to coding guidelines, maybe an additional code. Maybe that's something that needs to be brought up to the physician to clarify. So to me, that's the answer.
Yeah, I think the important thing here is really that is a coding question, and it illustrates the point that you know the goal of CDI is somewhat different than the goal of coding. Interpreting a coding guideline is the coder's responsibility, and this is a documentation issue, and that's where the query would come in. Is, hey doc, you stated that the patient has diabetes of manifestations, but you didn't state what the manifestation is. So there, that is the documentation improvement opportunity, not so much the coding guideline.
And I think this question leads to a very good point as to there are coders who have less experience, that they're not as confident that they have enough medical background to decide when it is time to write a query. Basically, one way to tell is if you know there's a code for specific conditions, in this case, DM with renal manifestation, and according to the coding guidelines, you're supposed to assign an additional code for the specific manifestation. And when you look at the documentation, when it is not there, then there you go. There's a chance there is the query opportunities because there is a code for that. There should be a code for that, and because it's not documented. So, so meaning we should, if you have access to the physician, do a queries and ask for more specific what exactly is the manifestation, so you can assign the appropriate code.
Yeah, it's also educating the physician. Sometimes if a physician give you diabetic mellitus with a renal manifestation, they're trying to kind of do something about, after diabetic. You may even get just diabetic when the patient has a lot of diabetic nephropathy and other things, okay? So it's also how far could the physician go, but it all depends on that the physician know the specific things what to put when they put the diagnosis. So it's just not only a coding issue or a clarification issue, but also educating the physician, giving them different leaflets, different things, so they know how far they should specify the things. In their mind, in their assessment, that probably is the most specific diagnosis, diabetic with renal manifestation. But when it comes to the coding part, like you may not code that, but you need a little bit more of specification. So you can go ahead and query a physician, but at the same time, the physicians has to be well educated about the specification of different conditions.
So coming up on the end of our hour, and we want to thank Dr. McKinnon and Brian for bringing their expertise to our inaugural session, and they will continue to bring their expertise and their knowledge and their insight to our future sessions. So we do certainly hope that you will be joining us for as many of the CDI forums as you can join us for. Remember, each one is worth 1 CEU for participating in the live presentation. And so we do thank you for being with us. Don't forget, we are here Mondays and Wednesdays at 7 o'clock Eastern Time. Wednesday, December 2nd, join us for the query and overview. We did discuss a little bit about queries tonight, and Dr. McKinnon and Brian Quay will discuss the query in a broad overview on Wednesday night, and in future sessions we'll break down the query into its individual parts and areas of concern. So that will be Wednesday, December 2nd, 7 o'clock p.m. Eastern Time. Your CEU certificates for participation will be emailed within 48 hours to the email that you used to register for the event. And for any information on upcoming or existing Coding Academy courses, you can visit www.compliantcodingsystems.com or www.compliantcodingsystems.learnupon.com/store. And again, we do thank you for being with us for this hour of the CDI Forum, and we look forward to seeing you in our next session. Thank you, everybody.